Hi everyone, my name is Arielle Bloodsaw. I'm a nursing student at Lamar University, and I do have the opportunity of teaching the techniques for effective aggressive management training program. I've been a nurse for 3 years, and I have witnessed how critical it is to be aware and prepared to effectively manage violence in the workplace. So for this course, I'll go over the objectives with you all. We will recognize specific hazards associated with working in a healthcare setting. We will discuss the 4 types of threats and appropriate responses for each, identify the characteristics of an aggressor, recognize early warning signs of escalating behavior, describe the effect and impact of aggression in healthcare, discuss the management of aggressive behavior, and demonstrate techniques for effectively managing aggression, describe effective strategies to enhance communication and build relationships, apply the aggression cycle, and identify progressive patient control methods, their application, and their associated risks. So, first we'll start by introducing ourselves. Well, I already said that I'm Arielle, and then I'll let Jenna introduce herself.
It's Jenna Mendoza, the educator on 3 Tower.
So we'll let you all introduce yourselves. And I will be moving over to the side so that you all can focus on our screen and have a great learning experience.
They got to the room fairly quickly. The patient was really verbally abusing us at this point. Then he lunged at the nurse. I remember trying to tell him to calm down when he pushed me against the wall. I hit my head very hard. I don't remember anything else.
Okay, so it's time for some interactions. How did this video make you all feel?
Anybody seen this before?
Yeah.
You got people do.
Yep.
Do you have an experience you could share?
I had a patient that was, she came in and she wanted to be evaluated for psych, but we had to rule out, she'd gone to the psych facility. They said, if you want to do this voluntarily, you have to go to the emergency room and make sure you're medically okay. You can't have any medical acute problems if you go to a psychiatric facility that can't offer medical care, just they offer the follow-up. And so we evaluated her. She was fine medically, so we started to talk about, you know, what she needed after that, and just make sure she wasn't actively suicidal before we discharged her. Apparently, the doctor went in and talked to her, and she was kind of, I guess, playing the word game with. I think she wanted us to commit her involuntarily, but she didn't want to say it. And I think she toyed with some words, and there's only a couple of words you could trigger in the emergency room when you become a suicide patient. And she didn't realize it would go there. And so she was screaming and loud. I think sometimes it's overkill, though, with security charging in there before you can talk to them. Like, they didn't give me a chance to talk to her. It was just, here's the word, call security. And that, I think, caused her to get more physically aggressive. She wasn't physically aggressive at first. And I think sometimes it is preventable. Like, instead of calling in the cavalry, give them a second, diffuse, you know, just talking to them. But unfortunately, because events, there's always one event that hurts someone that causes, okay, from now on, that's it, security's in there immediately, we're tackling somebody. And I think that's overkill a lot.
Do you feel that?
Oh yeah, we get called, as soon as someone raises their voice, we get calls. And sometimes people are calling up and say, well, give me just an extra minute, let's see what we can do. But the reason why people are going through this class is so that you all feel more confident in those situations before it gets to that point that you realize that, hey, maybe I can do a little more before we need to get to that. Because if it gets to the point where we have to lay hands on someone, a lot of times somebody gets hurt. It can be the patient, it can be us, it can be the nursing staff. You know, we don't want to rush to that if we don't have to. Now, if it gets to that point, or if it's someone that we know that you know, they could escalate, then we'll do what we have to do. But if we can talk to people and try to keep them calm, that's always considerably better.
Would anyone else like to share an experience?
Unfortunately, the incident you just witnessed is not uncommon. Perhaps the situation in your environment is a little bit different, and the scene may look a little bit different, but unfortunately, an aggression is happening all throughout healthcare. Well, I'm Tony York, Chief Operating Officer of HSS and author of Hospital and Healthcare Security. The frequency of healthcare violence continues to rise and has been rising for the last 10 years, something that we all have to be concerned with. This program has been designed to help you confidently manage violence and aggression, if not altogether avoid it when you're faced with it inside the healthcare environment. We don't want to scare you, but we want to help you understand when this situation happens, you can't confidently manage violence and aggression inside of healthcare.
Okay, so more than 5 million U.S. workers are exposed to many safety and health hazards. Most of the workplace violence is, as you can see with the law enforcement, with 48, and mental health, and retail sales, medical, and teaching. So the workplace violence is pretty much everywhere. It's going to be some type of workplace violence, and we want to try our best to prevent it and to de-escalate it as soon as possible to prevent it from going, any further. So with workplace injuries, as you can see the numbers, so we have healthcare has a very high number of cases with workplace injuries. So some factors that contribute to problems of violence in healthcare is societal factors, increased presence of criminal activities, prolonged wait times in the emergency room. Just like you were stating, a lot of times the patients will be in the emergency room and they'll be upset because they're waiting so long, and then they're angry by the time they get to the back because, they've been waiting so long, and it's like, I'm sorry, I just met you, but they're upset, and it may not be anything personal, but just because of the situation. So alcohol and substance abuse, economic conditions, the use of emergency departments by law enforcement, unavailability of psychiatric treatment centers, and increase in weapons possessions among patients and visitors. So with the wait time, as you can see, like in 1997, it was like a 20-minute wait in the emergency room, and then 2004, like a 30-minute wait, 2007, about a 4-hour wait. Now in 2014, it's no telling how long you'll wait in the emergency room. I hear some patients saying, they're waiting for like 24 hours to be seen. So, I mean, being a patient on the other side, I can understand the anger, but we want to try to talk to them and, keep them calm and do our best to try to keep everyone safe.
Hi, my name is Larry, and I've been a security officer for 7 years. In the past 7 years, I've seen many types of violence happen in the healthcare setting. I'm here to give you a better understanding of the different types of violence that may occur where you work. Workplace violence is considered an act which threatens the safety of an employee or others in the work environment. It can occur in many forms. Some you may see more than others. OSHA defines 4 different types of violence that can occur in the workplace. Violence with criminal intent, violence directed at staff by patients, co-worker to co-worker violence, and personal issues spilling over into the workplace. The most common types of violence we see in the workplace is directed at staff by patients. There are many factors that can trigger patient-centered violence, such as the patient feeling that they are receiving unfair treatment or the time it takes to wait to be seen by a doctor. Recognizing these early warning signs can help you manage aggression in the healthcare workplace. Although patient-centered violence is of great concern, there are many outside factors that you should be aware of. For example, robbery and theft of prescription medications from pharmacies and emergency rooms, as well as workplace violence by staff members towards other staff members. Recognizing the risk factors and the most common types of violence in the healthcare setting can help keep you safe and allow you to focus on the safety of your patients.
Hi, my name is Darcy, and I've been in the nursing field for 15 years. What you just heard from Larry is not uncommon. 54% of nurses reported having experienced physical violence and or verbal abuse from a patient during the past 7 days. What is even more surprising is that 70% of violence and abuse that occurs in a healthcare setting goes unreported. When violence occurs in the workplace, it not only has an impact on an employee's physical being, but also on their emotional and psychological well-being.
Okay, so we'll look at case study.
A patient was placed on an emergency detention order, a mental health hold, and admitted for detoxification. The patient made repeated threats towards medical staff, and when attempting to leave the room, he kicked over a piece of medical equipment, breaking it. He then proceeded to throw a clipboard at the nurse and kick and punch the security officer.
Okay, so I want you all to go to page 7 of your workbook. And at the bottom is questions for reflection. Take a look at the, no, I'm sorry, it's page 9. And we can discuss if anyone wants to, you know, discuss the first question. Have you ever experienced some form of aggression in the past? Anybody?
Nobody's experienced any aggression?
I had a patient on, what's that new drug called? Some zombie one? Bath salts. He tried to bite me. My arm, maybe it was my fault, my arm was over. He did, he tried to bite me. So I'm gonna bite him back. Good. Can't do anything about that.
No, well, sometimes you can't do anything about it whenever it's even because their ammonia levels are too high and they think that you're somebody who wronged them out in the real world and stuff. I mean, some of it you just can't do anything about it except for try to take care of them out there and not get hit. So I mean, it is part of our job to protect ourselves from it because it happens every day.
Yeah, exactly. Yeah, it does happen every day. So we'll discuss like the common injuries. Like you said, you got bit. Most of the injuries happen in the upper extremities, head, face. I know I've been scratched, I've been kicked, punched, everything. So the different types of injuries include, we get bruises, blunts, forced trauma, cuts, scratches, and exposure to body fluids. You know, some of the elderly patients like to spit on you and they can't reach you. You know, so we want to...
People are tied down, not a lot else they can do but spit and try to bite.
Exactly. So later on in the advanced portion, he's going to show you what ways to avoid, you know, any of this. Sometimes it's hard to avoid it, but Mr. Todd here will teach us some techniques.
Work on some stuff that maybe will try to help.
Yeah.
It's not going to eliminate everything, but maybe it'll at least try to help.
Exactly.
Come back, Jamie.
So now we'll focus on the difference between anger and aggression because, you know, it is a difference. Anger is a natural, normal, and valid emotion, and it can be manageable. While aggression, it's not an emotion, it's more so of a behavior, and it's a negative behavior that causes destructive behavior. So everyone has the right to be angry, but we want to try to prevent this aggression. So we already did this self-reflection with the personal experience. So we have an aggression spectrum, and a lot of situations start with intimidation, and it kind of escalates. So what we want you all to be able to do is de-escalate it to where it doesn't get to the physical, assault. So it's a lot of different techniques that we can do to try to de-escalate it. So first, with intimidation, as you can see, it's intentional behavior that will cause a person of ordinary sensibilities to have fear or of injury or harm. So some people, they will, just try to intimidate you with simple words, or even just they'll verbally attack you instead of communicating. They'll try to humiliate you, or even use sincere tones to get what they want. So you just have to watch those type of people that try to intimidate you, because it's a form of aggression. So we have offensive languages and sexual innuendos. Okay, so for the offensive language, of course, most of us have experienced patient, even staff members, with the offensive language. And it could be a form of words, expressions, gestures, and other social behaviors that are deemed disrespectful. And so the sexual innuendos is indirect intimidation about a person or thing, especially of a derogatory nature. It can be in the form of a remark or question.
And even if you don't feel like you need necessarily us to rush in and do anything, if you're getting any kind of intimidation or sexual innuendos, anything like that, let us know. I mean, if nothing else, but to protect yourselves, to show that, look, this patient's demonstrating, or patient or staff member is demonstrating this type of behavior. I just want people to be aware that this is what we're dealing with. And if it gets to the point that you feel like we need to intercede and step in, or the OA or physician or something like that, we all need to know. Don't just say, oh, it's okay, he or she's just, they're just speaking out of their mind. They may or may not be. Either way, we want to know. We need to get it documented just to protect yourself also.
So verbal abuse, it may consist of shouting, insulting, intimidating, threatening, demeaning, or like we said, the derogatory language, among other forms of communication. So, with verbal abuse, like I said, even with employees, you want to, try to let someone know if you feel like they're, abusing you verbally. Sometimes you can address the person because they may not know that they're being offensive. So you want to try to address them, and if you can't handle it, then you want to, use the chain of command to try to get the situation handled. So you want to try ways to prevent. So prevent and respond. So you want to call it when you see it, document it, be safe and aware, and be mindful of the things you say and your message. So then with the verbal assault is a negative defining statement either told to a person or about a person. So we want to watch the words that we say, because we can not only be the ones being assaulted, but we can assault others. So physical assault is the highest of our spectrum, in which we want to try to prevent, and it's an intentional act by one person that creates an apprehension in another of an harmful or offensive contact. So what is a threat? A threat comes in a variety of different ways. It can be spoken, written, symbolic. So So there's different types of threat, 4 different types of threat. You may have an indirect threat when someone says, like, you're going to pay for this. You may have a veiled threat if they say, I've got my gun in the car just to get you to do a certain thing. They may say, I'm going to break your neck, I'm going to kick you, or I'm going to do this or that. That's more so of a direct threat. Or I will hurt you if you report me. It's conditional. At the end of the day, you still want to make sure you use your chain of command to report this, because if you stop it at the beginning, it will prevent from going to the further stages.
For those that don't know, threats are criminal offenses.
Yes.
A terroristic threat can be reported to law enforcement if it feels necessary.
So we'll talk about the levels of threat. Starting with the low level is more of a minimum risk, but the threat is vague and indirect, and information within the threat lacks details. With the medium threat, it's more serious. It's more serious than, of course, and it could be carried out, although it appears unrealistic. And then with the high level of threat, it's the most serious type of threat, and the person, the threat is more specific and plausible. So we'll have another case study.
A woman and her sister were at a hospital visiting a patient in the ICU. While in the ICU waiting room, the woman's estranged husband approached her and an argument ensued. At that point, the husband was asked to leave by hospital security. On his way out, he told his estranged wife and sister-in-law that they would be sorry. He left, got his gun, and returned to the hospital waiting room.
People been shot. Go. It's not a patient.
Hello?
Honey, I need EMS to the Hutchinson ICU. It's had 4 gunshot wounds. I have two visitors that have been shot, and I need EMS to come help us.
Okay, man, yeah, they're on their way.
I need to tell them to come to ICU waiting. Right over them, that's where I need to go.
You got 4 victims?
4 people shot.
Okay.
At least 2 on the floor. We need help as soon as possible. I need some paramedics up here to get these people transported.
All right, I'll let them know, ma'am.
All right, thank you.
All right.
Very sad case. So, after what you just heard, how do you feel about the situation? What do you feel the healthcare providers could have done to possibly prevent it?
Did they even know that he had
Right.
him?
I think they was right there when he said it.
Uh-huh.
Yeah.
So,
They should have
taken
them more serious.
exactly.
They should have taken it more serious.
Okay, yeah, 'cause
Nobody ever thinks it's gonna happen to them, so
Yeah.
nobody ever takes them seriously.
exactly. So this could have been prevented. The staff could have responded promptly and immediately when he told, when he threatened them and left. Could have maybe got the patient family member in a safer spot, or maybe moved the patient. So it's important to not downplay or minimize the threat, because even though we have a few people that say I'm gonna do this and I'm gonna do that, they may not carry out with it, but you still want to take it seriously, because you never know if they're gonna carry out with it, and you don't want to risk, like in this situation, losing lives because we didn't take it as serious as we could have or should have.
Did everybody take their shots fired pill? Everyone seen that on pill? So on pill, it's called shots fired, and
Took it last year.
you took it last year. Okay, good. So it came out about a year ago now. But it's kind of how if a shooter came into the hospital, how you would need to respond, and what the best way to keep you safe. Those situations sometimes you don't know what to do, but I think the video does a good job of trying to at least inform you of what you should be doing. So if you haven't seen it, it's only, I think, 5 minutes?
Yeah, it's not very long.
It's not very long, so.
So what type of threat would you say this was in this case study?
Carry out.
She said direct.
Yeah, that's correct. It is a direct threat. So when dealing with a similar situation, we talked about what could have been done to prevent it, but what other approaches might we have tried?
Well, if you don't have a visitor making threats in your unit, then they gotta go, right? They'll need to call us, they need to be escorted out, we need to make sure they leave the property. If they need to, depending on what threats are made, contact Humboldt PD. We're not going to allow that, especially in patient care areas, especially in high-stress environments like the ER, the critical care units, places like that. We don't need drama, especially just from visitors, even if they're family. Everybody would agree with that, I hope?
Yes. Okay, so we'll talk about the factors that contribute to violence.
Aggression can take place anywhere. Being aware of your surroundings can greatly decrease your chances of encountering a potentially violent situation. 15% of violence that occurs in a healthcare setting occurs in the admitting or triage area. 15% of violence occurs in the nurse's station. 1/4 of the violence occurs in a hallway, stairwell, or elevator. More than 80% occurs in a patient's room. There are many situations that can lead to aggression. That's why it's important to de-escalate a situation before it turns violent. When you're alone, your risk increases significantly.
Okay, so do you all believe in the statistics?
Well, I've seen this poster in the break room in the ER. Why is it more than 100% in total?
Because it can occur in multiple places for one incident.
Okay.
Like, were you here that night they had the psych patient come into the ER lobby, and he ended up walking through the break room, down the hallway to HR, everywhere before.
So all of that would count?
Yeah.
Okay, I see what you're
It
saying.
happened in multiple locations, but it was just one incident.
Okay.
It started with us.
Because it normally does.
Starting with the ER, yeah. And that's one thing we're gonna talk about is, in that case, nobody from the clinical side, the OA or anybody wanted to make a decision on, was this person considered someone that we needed to keep here or to escort it out or whatever. By the time they made a decision, it already got out of hand.
Wow.
So that's something we need to keep in mind, especially with psych patients. If you have a concern that they're going to get aggressive or hostile, or we need to get what am I looking for? Direction from someone in charge or someone that's willing with their nursing license or their physician to say we need to restrain this person or whatever we need to do. We can't just let them wander around and continue to grow aggressively and get more hostile. That's how somebody gets hurt. And in that case, the patient got really, really, really hurt.
But how do you determine, like, if they're, say you're on the floor upstairs and you're in the hall, we have a lot of muscle in the emergency room that we can call. Before we have to call you guys, and if you're staying in your right state of mind and we ask you, okay, sit down, let's talk, or come back into this room, or whatever, and they're willing to do that, okay. If not, and it gets aggressive, like we had a lady, she had a restraining order against a guy, it's a piece of paper, well, she didn't throw it at him. He came back in there and he was yelling, it was towards her. And at that point, I'm restrained now and ask questions later. But if it deems that he maybe shouldn't have done or unlawful, like, they can come back and sue,
These, for restraints, not for arresting, not for handcuffing, for patient restraints, first of all, physician or any medical person with a license, if they think they're willing to put their license on the line and say, look, they need to be restrained. As long as they get a physician to look at them within an hour, I believe it's an hour, right? Mm-hmm. And make an assessment, we can put them in restraints before they get aggressive.
Oh.
We can't make that call. Non-nursing staff, non-physician staff can't make that call. So if you think it's going to get to that point, and you have time to get a physician, say, hey, look, we need to put them in restraints. Or if there's not a physician readily available at that moment, you're like, no, we need to do it. It keeps them from getting hurt.
But non-patients too.
No,
That's what I'm asking.
non-patient, if it's a visitor, like in this case, if she had a restraining order against him, call us, and we'll just make him go right then. He has no reason to be there.
And y'all did, but like that psych person who might be walking off the street, we don't realize they're psych, but they're
Right.
not a patient officially yet.
And
then what?
that's a gray area that risk management's having all sorts of problems with right now. Because we just had an incident down, we have the crisis center down the street now at the 9813 building where they're outpatient psych. They're not gonna take people who don't wanna be there, but people normally come there because, they feel like they need help. And while I don't know if it's taking some of the burden off the ER or not, that's supposed to be the point of it. What happened was, a 24-year-old female was brought in by her parents. Once she got there, she refused to go in. She So I don't need it, I don't want it, you can't make me. So she went out across the street to another building. While she was there, and while they were trying to sort out what they wanted to do with her, she ended up slapping somebody. And nobody got seriously hurt, but it came down to, what can we as security and nursing staff do for this person who doesn't want to be here and isn't demonstrating any reasonable signs of psych issues right now in front of us? As soon as she got combative and hit someone, it became a criminal incident. We were able to get the police involved, and it worked out. But if someone comes and we don't know, someone's just telling us, oh, I think they're crazy, they need to come in. You need to put physicians in OA, need to make that call if you're not sure yourself. If you don't see any reason to believe that they're, that they're psych or that they're going to be a problem, you just treat them the way you would any other patient. If it gets to the point where they're getting aggressive and violent, we can restrain them on our own. We don't have to wait for someone to say, we need to do this. I don't like that either. I worked nights for a long time, and we get people that we brought in, and one person seems normal, the other person says, oh no, they need to be here, they're not right. It's like, why are we listening to this person when this person says they're okay? There isn't a good thing for it right now. Risk management's been meeting, we've had, 3 meetings in the last month regarding a couple incidents across the system that they're having like that, where they're trying to say, well, we need to be more proactive, but at the same time, how do you be proactive without taking away their civil liberties? I don't want to be one of the higher up people that has to make that call.
You want to be at the bottom either when you get.
Well, that's why you follow your chain of command and do what they say to do. And if it gets to the point where we can't wait and they're getting aggressive, we'll restrain them, and that's just how it is. Because patient safety and life safety has to come first. I don't know if that helped at all, but trust me, they know we're all wrestling with that issue right now. I've got officers that are afraid to lay hands on people if they're not in a patient room because they're not sure if if they're allowed to or not. Because they don't want to get their license. If they get their license taken away, they don't work at all for like 10 years and insecurity. So it's a problem for all of us right now. Thankfully, it doesn't happen too often, at least not right now.
Okay, so we'll discuss the high-risk areas. So as you know, the ER, it does remain one of the most dangerous workplaces for RN and medical staff due to the patient-centered violence. There's also a high risk in the psychiatric units, medical units, or floors, or surgical units. So I have another case study.
A stat call was announced on the overhead page to the ED. During the response, yelling was heard throughout the ED. Upon arrival, a man was pacing in the middle of the waiting room, threatening to hurt someone if his ill brother was not soon seen by a doctor. Security was called as medical staff began to verbally de-escalate the situation by explaining that his yelling was disturbing patient care in the rest of the ED and as a result was prolonging his brother's wait time. He continued his threats. The security supervisor responded, and as a team, both security and medical staff listened to the man's concerns for several more minutes and continued to explain the triage process. Managing expectations is an important component of verbally de-escalating potentially volatile situations. The disgruntled family member vented how he and his brother had been waiting for 2 hours, which has resulted in a negative experience. The team explained it was standard hospital procedure for patients to be seen on a priority basis. They also said they would see if a doctor was available to assist his brother. The team offered the disgruntled man a cup of coffee and offered to change the channel on the TV monitor to a channel the man desired. The man sat back down and remained calm until his brother was seen by medical staff.
Don't give angry people hot coffee.
Right. That's a bad idea.
Offer them some water.
So a few important things in this case study. You want to try to manage the patient or even the family member's expectations, which is very important in de-escalating the issue, because just like this issue, once the patient or the family member, understood, like, okay, sometimes you just have to let them know, hey, your family member is 2 in front of this patient. And I noticed in our ER they're really good at letting them know when they come up, well, I've been waiting for 7 hours. They'll let them know, okay, it's 2 people in front of you, and then you'll be seen. So you want to try to, manage their expectations and try to make them more comfortable and listen to what they're saying, because sometimes, from the other party standpoint, everyone feels like they have a valid point, and you know, you just want to try to listen to them to make them feel and understand. You know, we do feel bad that you've been waiting this long, and we'll get to you as soon as possible. So, characteristics of an aggressor. You know, aggressors tend to typically be male. Of course, alcohol has an influence on that. Behavior and the health of patients, drugs, geriatric patients, trauma patients, and pediatric patients. I would say personally, I've had more issues with geriatric patients. I've had more, you know.
Yeah, don't take them for granted.
Yeah.
They seem fragile and weak, but man, some of them they've got like old person strength, and they'll kick you in the chest and you just won't, you'll be done.
Yeah. And they are pretty strong. So, what are some risk factors? Of course, transporting patients. So, transporters, you all are at risk too. Overcrowded or uncomfortable waiting areas, working alone, poor environmental designs, lack of training, not actively aware of surroundings and environment, and unfamiliar environment. So, what can we do to identify some risk factors in your area, in your specialty area? Participation.
When you guys are working in the ER particularly, you know, you're in a patient room, how do you keep yourself aware of the environment?
No closed doors.
Good.
Doors stay open. No more than one person in there if they want somebody with them. Like a lot of family in a closed room. Our rooms aren't that big. And that just over inhaling, I think, carbon dioxide or something to make people get angry. Visitors are hungry and, you know, just, it's tough.
In all the units, do y'all think about escape routes if you need to get out quick or if there's something going on? How to not get cornered in? Does anybody think about that sort of thing? I mean, all the units and areas have multiple ways to leave, but if you get stuck in a corner, what do y'all think about that? Some people?
Yeah, if you guys are gonna, when we talk about the sitter portion, we require you to be sitting at the door and with the door open. Because you can get pushed up against the wall with the bed or any other type of, any other environmental factors there, you can get really hurt. So we always want to make sure that's the biggest thing, is being aware.
So the next slide is gonna, we'll identify who is at risk. So pick what individual you feel is at greater risk for violence. So in page 18 of your workbook, you can look at each picture and circle either yes or no. If you feel the healthcare provider is at risk or not. I'll give you a few minutes. Okay, so we'll look at each picture individually. Okay, so our first lady. So why would a nurse walking into a patient's room who is looking at or reading a patient's chart be at greater risk? Exactly. So you gotta pay close attention to your surroundings and what's going on. Yeah, exactly. So what could the nurse do to avoid the risk?
Put whatever that is in our hand down. Whatever.
Back behind the computer.
Exactly. So you wanna focus on what's going on. So why would this person that's working alone in the pharmacy be at greater risk? Yep, she's not paying attention, and then she's in there alone.
Looks like she's working in a nursing unit late at night here. Reading a book, playing on an iPad.
We have no idea what you're talking about.
No, y'all don't need to read the units either.
So and this lady is walking to her car in the parking lot on her cell phone.
Looking for keys.
Does anybody here honestly do this?
No.
Never?
I did it once and I never did it again.
I know,
What's
right.
that?
I did it once. Wait till I get to the point of getting the keys.
We did have a nurse, 5-tower nurse, she was robbed at 9 Point two years ago now. It's the only one I know, I've been here 11 years, it's the only one I know of since I've been here. But the guy that did it, they don't have him. He's hit a number of different places in the whole area, they still haven't caught her. She didn't get hurt, she just lost her purse, but it could have been way worse, and she hasn't been the same since, I'm sure. I mean, that's a stressful situation. It's tough to get over. And if you're not paying attention, especially late at night, you're walking across the parking lots, we're, generally speaking, when it comes to violent crime, we have very little on our campus, very, very little. But that doesn't mean it can't happen if we're not watching what's going on. We do get vehicles broken into now and then. We average about one a month, which in the scheme of things is actually very good. But that one a month, that person could be violent. And if you're not paying attention, it's, what if it's your car that they're in when you get there and they freak out? I mean, you've got to pay attention. If you're leaving alone, please call us. We'll give you a ride. We'll watch you. Something. Don't hesitate to call us. It may take us a day or two to pick you up if we're busy, but we will, and it's much safer. Okay, just throwing that out there.
So being aware of your surroundings at all times and being aware of how others perceive you is important. So your goal is to avoid situations where it can lead to aggression or violence. So you want to always rely on your team and always have a safety plan in place. I know, especially when I was pregnant, if I get off late, I will call security and they'll take me to my car because I'm scary. So I didn't mind calling 7777 so that they can come in, and they do it. They don't mind. They're really nice about it. So even males sometimes they can try to get you too. So just call security. They don't mind helping escort you to your car.
All of us have that X in our past that you don't know what they might do. So just be careful. And policy states you're not permitted weapons on property. But if y'all have some pepper spray or a taser or something in your purse, don't tell anybody. Just keep it handy when you're leaving. You know what I mean? Don't use it on patients or anything. But if you got something, just keep it to yourself just in case.
Okay. So let's look at the mindset of the aggressor. So when you walk into a room, you want to walk in with confidence and keep eye contact. You have less chance of being a victim, because when you walk in with confidence, I notice a lot of times, like if a nurse may be timid, or if you go in looking timid, then either the family member or patient, they'll try to be aggressive, even like with something so small as pain medication. If they notice, if they feel like they can get over on you, they will try to get.
And this is true. There was a study done with law enforcement officers with prisoners that had assaulted law enforcement officers, and almost all of them, when asked why they chose the officers they chose to hurt, they picked the ones that looked sloppier and looked like they weren't able to take care of themselves, the ones that didn't look confident. And this applies to all of us. If you go into a situation or environment and you don't look like you know what you're doing, you look hesitant, you're not sure, they're going to pounce on you, even if it's just to pick on you because they're unhappy with their service. But if you go in there and you know what you're talking about, and you look like you're ready to go, and you're confident, you're not going to have as many problems.
Exactly. So those who practice aggression on the street are typically cunning, cheating, and they don't have any rules. So You know, they're gonna try in the healthcare setting, they think nurses make money or people at the hospital make money. So like you said, with the 5-tower nurse, they think that we all have money. So, you know, you want to protect yourself and be aware of your surroundings. So there are factors that contribute. So unrealistic expectations. They may think I will be in and out for an hour or two tops. So if the patient come in with that attitude or with that mindset, if they're here for that third hour, then they're easily angered. Anxiety or fear, bad previous experience, the finances, how can I pay for this? I don't think my insurance will cover this. Or insecurity, loss of control over one circumstance. So we'll pause here and we'll let you take a brief break. You can use the restroom if you want. And we'll start back up. We'll start by discussing the effects of aggression in the workplace. So aggression and workplace violence in the workplace can lead to both physical and psychological trauma. You know, impact relationships outside of work, impaired concentration, dissatisfaction with your job, increase in absenteeism, reduce focus on patient care. Anytime violence occurs in the workplace, there's usually a cost associated with it. Just like you said, the woman left here and went and slapped the lady at somewhere else. So the risk factors, there's personal, communal, and medical risk factors, just like we discussed in the previous slide. So communication difficulties can be pathological, culture, or language difficulties. Then you have your social problems, like interacting with others, to include ineffective coping skills, grown up in an environment in which rewards aggressive behavior. So, you know, as we all know, we're all adults, so and everyone comes from different places. So, you know, the way I was raised could be different from how another person was raised. So, just my background, I could say a certain thing and think that it's fine, and to another person it could be rude, but that's just how I was raised. So, we have to try to understand everyone's just different backgrounds and culture. So, pain management. Lead to pain-induced aggression, so which can be a form of self-defense reaction to the pain itself. A lot of times, as you know, we have our frequent flyers that want our pain medicine every 2 hours or every 4 hours, and they act up to get that pain medicine. They will do anything possible, you know, by all means necessary to get their Dilaudid. You know, everyone wants Dilaudid, so. Once again, it's important to protect yourself, and I know when I worked on 3 towers, a lot of times we had to call security because of how the patients act up, and it's like, you acting up like this and you want me to give you pain medicine? So just have to be mindful of all of the risk factors. So community risk factors is economic conditions and the resulting crime rates. Have gang activities, so antisocial behaviors, alcohol and drug abuse, and aggressive behaviors. Seasonal trends, an increase in temperature has also shown that. So medical risk factors is the alcohol and substance abuse, the head trauma, the psychiatric illness and anesthesia, and Alzheimer's. So with head trauma, we all know that it could be non-visible signs or even visible signs such as bleeding, uneven pupils, infection and fever, high fever, headache, and disorientation, and then intoxication, psychiatric disease such as schizophrenia and bipolar. So what are daily things that could present significant risk for you, just, you know, as a nurse or transporter? So let's just say, like, with the utensils, you know, when we have the patients, the suicide patients, we give them the plasticware and everything, because if they just use like the regular forks or knives or something, they could be a harm for the patient and for us. Money exchange, you know, when there's things with money, you risk for being robbed or anything like that. So with the when drugs are dismissed, like in pharmacies, I've also seen on the news a lot of people now are trying to rob pharmacies, I guess, to sell the drugs. Exposure to aggressive.
We have all of these here, by the way. Everything on here, we do this at the hospital.
Yep. So in high traffic areas, like in hallways, so basically we're pretty much all race, every race. So once again, it's important to, you know, pay attention to your surroundings and be aware. So I want everyone to take a look at this nurse and tell me what could be a risk for her.
Stethoscope.
Uh-huh.
Her badge, her lanyard.
Her hair.
Yeah.
Clipboard.
Yeah. So you said it, the stethoscopes, the earrings. See her earrings, a little dangly earrings. The scissors. I don't see any scissors.
That's a
They're down here. You don't see them.
Oh.
You don't see them.
Right.
Her ID badge and her long hair.
Yeah, if you're gonna wear the ID badge around your neck without a lanyard, they make the breakaway lanyard, so if you tug on it, it just pops off. Don't use that, otherwise that's a choking hazard.
So we'll look at the safe room, and it'll divide the room into levels, and we'll go through each level. And I want you to just tell me, you can shout it out. In level 1, what do you see that could be unsafe here?
That light.
Uh-huh.
Glass.
Up here.
That monitor right there.
Uh-huh. So what about in level 2?
Pillow.
Yeah.
And then over here, it looks like maybe you have like the blood pressure,
The cords.
cords, and all these cords.
Table.
The little table.
Suffocation by glove.
What do y'all normally have hanging on the walls at that level in the rooms that have?
The remote, the call lights and oxygen.
The sharps containers?
Oh,
Do y'all ever check the cabinets when after you had a psych patient or before you got a psych patient, anything like that, to see if they left something in there? Anybody?
no, but I'll keep it on. Why would they leave?
People leave stuff. The HPD leave his gun in his pregnant wife's room when they moved from LME to GOP.
Oh, wow.
Oh, yeah.
I don't think that's legal.
Well,
If it's concealed handgun.
we're not discussing legal, we're discussing this stuff
Right.
that happens.
So what about at level 3?
The trash can.
And what else?
Bed.
Yeah. What can happen with the bed?
They can run you over.
I'm at a bottom person, so I don't know.
You don't think about this.
Bottom line is anything can be used as a weapon if somebody wants to hurt you. I've had IV poles swung at me, I've had someone try to lasso me with a phone. I mean, anything can be used as a weapon. So if there's loose items in a room and you've got a violent patient or someone you think could get violent or confused, you need to be aware that anything in there, they could try and use that to hurt you if they really want to. So you need to keep that in the back of your mind when you're going into these rooms. That's why we talk about how important it is to make sure you know you have an escape route and get out quick. If you walk into that room and someone's holding up a clipboard with a steel edge on it ready to sling it at your face, be ready to back out real quick and call us, okay?
So when you walk into a room, you want to just scan their environment to make sure that it's safe. Because you want to protect yourself. Like he said, people, I have experienced people leaving things in the drawers and everything like that. So just when you walk in, even if you're coming to transport a patient, just kind of scan their environment, even the people, just to be aware of what's going on. So we'll go to some personal safety strategies. So things you should never do. You don't want to display anger, fear, or anxiety. Maybe you want to have your confidence. So walk in with confidence. Even if you may be a little timid, don't show the patient or the family member, because they'll try you could be a possible trigger for them. So do not argue or tell the person to calm down. So things you should try to do is to remain calm and maintain a lower tone of voice, use simple words, maintain eye contact, and acknowledge the other person using words which convey understanding.
And for, especially in the ER, if y'all have patients that, maybe they're psych or they're waiting on psych response or they're waiting on being transferred, be honest with them. So many times I'll get to a call of sitting with a patient and they have nothing to do but remember everything that everybody has said to them. So if you tell them, oh yeah, you're going to be out of here in 30 minutes, minute number 31 comes around, they know, okay? So just, you need to be honest with them. They will catch you up on it, and all it will do is frustrate them more and get annoying and frustrating for you as well.
So on this portion, we'll try to do some techniques to manage your emotions. So some people may have to go to the side and do religious things or take deep breaths or woosah. So we'll just practice taking some deep breaths. Everybody breathe in. Hold it. Now exhale. Just try to be relaxed, okay? So as far as staying safe, it's important to, be aware that you can call security anytime you need security. You want to make sure that you are familiar with your the policies and procedures so that you can know what is appropriate. And become involved in decision-making process by serving on committees which address the problems of violence. And make sure you report and document every incident. So the main thing you want to do is try to keep yourself safe and the patients and also your coworkers, and try to de-escalate any situations before it gets to being physical assault. Use your chain of command at all times. And that's the end of my session. So now we'll let Jenna discuss the communicating and building relationships.